Good afternoon, everyone, and welcome to today's Hopkins Hour online seminar. I know some people will still be joining us as we get started today, but we'll make a go of it as it's 12:32. We'd like to extend a warm welcome to all of our Hopkins Center members, partners, and collaborators who are joining us today. Before we begin today's proceedings, I would like to acknowledge the traditional owners of the land on which we meet virtually today. My office is on the land of the Kamberi families of the Yugambeh people, and I would like to pay my respects to the elders past, present, and emerging as they hold the memories, traditions, culture, and hopes of our First Nations people and of all Australians. We encourage all attendees to research the traditional owners of the land on which they live and work. For those of you who don't know me, I'm Kelsey Chapman, the academic research lead for the Dignity Project and a PhD candidate at Griffith University. It is a pleasure to welcome today my co-researcher, Angel Dixon, OAM, who will be presenting alongside of me. And I just ask that you excuse my coughing because I'm recovering from COVID. Angel is the citizen science research lead of the Dignity Project, and she was the 2019 Queensland Young Australian of the Year. She's the former CEO and current director of the Attitude Foundation and is a highly respected and regarded disability advocate. Today's Hopkins Hour focuses on creating systems that increase dignified experiences for people with disability. These critical findings were collected, analyzed, and synthesized through a range of studies over the past 2 years within the Dignity Project under the Accords flagship program at the Hopkins Center. Today's presentation is specifically targeted to policymakers, system and service managers, clinicians, and other researchers who have an interest in assuring that the systems and services that they design, manage, and work within promote dignified experiences for people with disability. Our hope is that by thinking through the recommendations we're going to outline in our presentation, you can transform the experience of people with disability in complex systems from one in which dignity violations happen all too often to one in which people with disability feel dignified, welcome, respected, and safe. Just a few housekeeping items. If you do experience technical difficulties, please feel free to put a question in the chat Q&A function, which is on the top toolbar. Macarla Kerr has put up a few reminders for people in the chat, and one of our event team members will try to assist you if possible. Internet connections, of course, will vary in this online environment. If you would like to enable closed captions, please press the 3-dot settings button and then select the CC icon, which will turn on live captions on the action list that appears. There will be an opportunity to ask questions throughout the presentation using the chat function on the toolbar. The questions will be moderated by our team, and we will address them towards the end of the presentation and also through the panel session. To post your question, just click into the chat function and enter your question and press send. We will answer as many questions as we can during the time, and any outstanding questions will be responded to after the event and sent via email to attendees. So at this time, I would like to hand over, it's myself and Angel, and we'll start the presentation. Excuse me. Go ahead, Angel.
Hi, everyone. Thank you for having us today, and thank you, Kelsey, for handing over. I will be handing back to you very soon. As Kelsey mentioned, my name is Angel Dixon. I'm a citizen researcher on the Dignity Project, which is a research and advocacy initiative of Griffith University and a flagship program at the Hopkins Centre. It was developed in response to research that revealed that people with disability and impairment experience violations of dignity and suffer inadvertent harm through systems of care. The Dignity Project is led by people with and without disability, citizen and academic researchers in partnership to deliver meaningful outcomes to social change that promote dignity. Over the past 2 years, the Dignity Project has undertaken a suite of projects to understand what dignity means for people with disability and how to ensure that people with disability have dignified experiences when interacting with mainstream services and systems. There's a lot of information in our presentation today, but the aim is to highlight the 4 key recommendations aggregated from across all of the studies conducted over the past 2 years.
Just a quick overview of the way in which we work at the Dignity Project, which is integral, of course, to Dignified research. We conduct projects and research with citizen leaders who are embedded throughout the research process to ensure that we're privileging the voices of lived experience. We use an extreme citizen science method, which is on the screen in front of you across 5 phases: vision, uncover, discuss, critical reflection, and change, which is, of course, an iterative process. And we use this to resist the normative dynamics of research and ensure that our research is more open, more inclusive, more equitable, and more dignified.
The impact of dignified treatment simultaneously impacts on people with disability, members of their support network, and on the systems and services with which they interact. Dignity is an upstream determinant of participants' experiences of healthcare systems, as it can directly influence patient and customer satisfaction, feelings of personalisation of care, and the delivery of optimal preventative care and services. Undignified interactions with systems and services can increase people with disabilities' feelings of dissatisfaction and humiliation. It can lead to withdrawal and social isolation and can increase the risk of chronically poor physical and mental health. Our research suggests that people with acquired impairments may experience an extreme juxtaposition between life before and after acquisition, making them more vulnerable and perhaps more aware of indignity. Here's a quote from one of our participants. "Undignified treatment makes you feel not worthy. To be honest, you feel less than human." Sorry, you may hear a baby crying in the background. My baby has just woken up from a nap. Our team is aware of the impact that language can have on dignity and recognises that everyday language plays an influential part on forming people's perceptions and identities. The Dignity Project uses person-first language, focusing on individual first, and if at all, disability and impairment second. We recognise and uphold each individual's right to self-identify the terms, pronouns, and language that's best for them, and we respect individual use of language and terminology. Where a person doesn't state their preferred language, the person first is used. We're giving a terminology note here because this is a through line throughout all of our work, not just on this particular project, but both Kelsey and I subscribe to this moving forward in everything we do. And disability in the context of this report, but also outside of our work, is grounded in the United Nations Convention of Rights of People with Disabilities. And it's conceptualized as resulting from the interaction between persons with impairments and attitudinal and environmental barriers that hinder their full and effective participation in society on an equal basis with others.
Dignity is a complex and multifaceted concept with a range of bioethical, philosophical, and practical considerations, which we're not going to cover all today. But the provision of dignity for people with disability is enshrined in numerous frameworks and pieces of legislation, including the United Nations Convention on the Rights of Persons with Disability, the Australian National Disability Strategy, and the Australian Charter of Healthcare Rights. Despite different origins, these documents all point to a multifaceted mandate for dignified treatment for people with disability across systems and services. First, dignity signals respect and thereby enacts human rights. And second, it increases the engagement of people with disability and in services and systems, thereby promoting better outcomes. Dignity is typically conceptualized as either inherent, something that people are entitled to on the basis of rationality, agential action, and autonomy, or as contingent, influenced and potentially violated by personal, cultural, societal, and relationship factors. Both conceptualizations of dignity present challenges for people with disability. People with disability are often denied full status as human beings by legal and societal norms and may experience limits to functional capacity as related to autonomy, rationality, and independence as typically conceptualized by mainstream services and systems. For people with disability, overt, covert, deliberate, and unconscious barriers across all aspects of engagement with systems and daily life increase vulnerability to violations of dignity. And therefore, despite the critical importance of dignity as articulated in legislation and frameworks, and as supported by people with lived experience of disability, it is necessary to move away from current conceptualizations of dignity steeped in normative dynamics of ableism. And that's what we set out to do in our research, is to begin to understand, what does dignity mean for people with disability, and how can systems and services ensure that they're providing for dignified experiences. Sorry, I'm just having trouble moving the slides. There we go. So, as a result of our research, dignity was defined as acknowledgement of people with disability as humans with value, agency, and preferences. This then required the delivery of human rights in ways that are responsive and respectful to those preferences.
So, unless you're creating something brand new, there will always be a mutable infrastructure that presents challenges to each of our outline recommendations. What we've strived to achieve with this recommendation set is to activate new ways of thinking to increase flexibility in seemingly rigid places. In many ways, these recommendations react on and rely on one another. Our 4 recommendations are universal design, or to minimize access barriers, improve system navigation and sense making with information, improve training and support for frontline workers, and create space for voice, choice, and independence. Ensuring equitable access to comparable opportunities and experiences is critical to dignity. Barriers, overt, covert, deliberate, and unconscious, negatively impacted on participants by creating a sense of dependency, increasing anxiety, and emotional distress, which increases social isolation. Dignified interactions were shaped by interactions between people, infrastructure, the physical, cultural, and digital and social spaces that they traversed. Excuse me. Universal design is a method of designing based on 7 key principles that work to make environments, services, and products usable by the highest number of people. Some of the universal design principles include flexible use, simple use, and tolerances for error. Oriented around all of these principles is the goal of removing barriers for all users. And eliminating access barriers increased feelings of independence, safety, and security, which means that minimizing barriers through the lens of universal design, or in my personal opinion, a universal and inclusive design hybrid, far outweighs creating specialized adaptations for specific types of people for a number of economic and logistic reasons, but significantly for the future of inclusion. Our key recommendations under this piece is decisions about funding and spending must include marginalized voices. Co-design and collaboratively identify priorities for improving access. New construction should always adhere to universal design principles, and to retrofit existing infrastructure, and where not possible, seek alternative means for inclusion. Co-design is an element which is present throughout each of our key recommendations. The act of actively involving stakeholders in design processes from the ground up, not just in final user testing, almost certainly guarantees optimum user experiences, effortless interaction, and ultimately business benefits. It also builds acknowledgement, which Kelsey has addressed, into the fibres of creation. Acknowledgement was a significant theme present in our research and a defining factor for people with disability when it comes to dignity. When each of the recommendations that we have here are met or addressed, people with disability are acknowledged not just on a basic human level, but as contributing and worthy citizens who can enjoy their human rights. In the case of immutable infrastructure, co-design is the best way to create flexible and inclusive systems. We have another quote here that says, "We live in a hostile environment. The built environment is so driven by risk management and limits. It's not human-centered. For me, a hospital is really hostile. It's really noisy and bright." Sorry, Kelsey, you're really struggling with those.
Sorry, everyone. The PowerPoint just absolutely glitched. And there we go. We're back.
There we go. We're back.
The joys of virtual sharing. Trying to see these little tiny buttons. So our next key recommendation is improve system navigation and sense making with information. Participants across our research engaged in sense-making activities by acquiring knowledge about personally relevant and experiential details, such as the location of amenities, parking availability, the inclusive nature of a care provider, where to go, and whether they might feel safe and comfortable in interacting or engaging with the system. Most of this information was gathered during what we call wayfinding, so sense making before they actually go in to interact with that system or service. Research participants described the importance of inclusive, accessible, visible, transparent, consistent, and accurate information as a mechanism for maintaining dignity. Dignity was positively impacted when information was easily and independently accessible, and when it could be used reliably to support sense making. Inaccurate and inaccessible information compromise dignity and increase participants' frustration and decrease their confidence in interacting with the system. Designing inclusive and accessible information for sense making requires attention to a range of factors. Information may be gathered from websites, mobile applications, social media, staff, fixed infrastructure, including digital and non-digital signage, by observing and interpreting what's happening, and from prior experience. Some information is dynamic, and some is changing frequently. Changing infrequently, particularly in the context of engaging with the system. Dynamically changing and emergent information needs to be communicated reliably and time sensitively in order to maintain dignity. Some research participants wanted to and needed to access information independently, and at other times, independence was enabled if they could engage with a staff member who treated them with respect and dignity. Irrespective of where a participant was situated on this continuum of information use, dignity was impacted positively when information was easily accessible to reliably support system navigation. Excuse me. So our key recommendations are, of course, that information should be accessible and inclusive. It should be visible and visual, audible and auditory, and easy to understand. It should be transparent and easy to find, should be accurate and consistent, and real time whenever possible. Participants discussed that specific consideration should be paid to visibility, audibility, language, and ease of consumption. Information should be able to be understood by people with diverse impairments, including those with mental health and cognitive impairments. Participants with cognitive impairment expressed difficulty experienced when reading information that was not presented in plain language. We propose that policymakers and system executives and clinicians should think critically about designing inclusive, accessible, visible, transparent, consistent, accurate information. It's a lot, but the way in which that information is communicated when it's done in multiple formats can be understood by the greatest diversity of people. It's not just for people with disability or impairment, but it improves the experience for all users. One of the important aspects of this is that it then enables participants or service users to decide how they choose to interact with the system or the way they choose for care to be carried out. So it's ensuring that there is independence in and choice in the way that people engage with the system. I'm going to try to move the slides forward here so I can share a quote. We'll see how successfully that happens. Oh, Mikarla's onto it. Thanks, Mikarla. Just to share a great quote about accessible communication and information. Accessible communication is key in order to reduce and limit fear. We have many means with mobile phones and technology to utilize accessible communication to ensure dignity. Accessible communication should consider all forms of communication, audio, visual announcements, plain language, and more. And that was from a staff member who shared that with us. Mikarla, do you mind advance? Thanks. So our next recommendation centers around the importance of frontline staff. And I know we have many frontline staff care providers, clinical and also industry here with us today. Diverse perspectives and individual factors can make it challenging for systems and for staff to ensure that they are maintaining dignity for people with disability. Almost all of our research participants across all of our studies, it was like 96% of participants mentioned staff, particularly health service staff and other frontline staff or service providers, as being critically important to retaining a sense of dignity when interacting with the system or service. Many interactions discussed by our participants illuminated positive experiences in which staff supported them by treating them like any other person, particularly during help seeking or when negotiating an access challenge. Staff recognized participants' individual impairment challenges and who acted in ways that preserved dignity, did so through calm and respectful attitudes, talking directly to participants as opposed to their support person, and showing empathy and understanding. However, we also heard from participants across all of our studies about the negative experiences with frontline staff. In instances where staff may have asked intrusive or unnecessary disclosures of personal information, had attitudes that lacked acceptance and understanding, and required participants to prove that they were disabled. This left participants feeling undignified and highly vulnerable. COVID-19 exacerbated many of these tensions with staff interaction, including making participants with disability feel like a burden or inconvenience. Interactions with staff often occur when encountering a barrier to access, when requiring treatment and care or other types of support. Often, participants identified that they were already experiencing a level of frustration or trepidation when interacting with staff for one of the aforementioned reasons. Relying on staff for assistance and support was problematic for many participants to retaining a sense of dignity. Participants felt dependent and that they were placed in these unequal, vulnerable, asymmetric relationships with staff who might control the outcomes, the access, and the information. Staff may or may not have awareness, training, and education about diverse impairments. And when they didn't, that increased participants' vulnerability to indignity. Our key recommendations surrounding staff are to develop environments that support staff to be engaged and empathetic, to address organizational pressures, because often it's actually not the staff member's fault, it's a system flaw or a system pressure, time, resources, skills, to increase the opportunity for staff to act empathetically, to identify and measure factors that contribute to empathy and respect for your individual service or system, to implement system-wide empathy training that's co-designed with people with disability, and to operationalize empathy for diverse populations. Attitudes towards and awareness of the needs of people with disability is of critical importance when ensuring dignified interactions. Failure to accommodate the needs of people with disability and undignified interactions were frequently noted. Factors that contribute to undignified interactions with frontline staff are likely to be complex, and we acknowledge that. It's not only limited to staff attitudes, awareness, and skills. Competing time and resource pressures, pandemic environment, the prioritization of services, and organizational policy all work to contribute to both positive and negative interactions with staff. Staff may need to adjust their communication style to meet the needs of people with disability. However, they may not have the skills, or adapting communication styles may vary. Staff are more likely to provide consistent, predictable, dignified experiences for people with disability if changes are developed together with staff training, favorable working conditions, and manageable workloads. It is necessary for communication behavior to change, but it's also important to understand the factors that constrain and enable that change. Developing environments that support staff to be engaged and empathetic is essential to maintaining dignity for people with disability. Empathy has been found to be associated with improved staff well-being and higher level of service user enablement. In order to achieve systemic empathy, which then influences dignified experiences of people with disability, services and systems need to emphasize identifying and measuring systemic factors that contribute to empathy and respect, implementing system-wide empathy by learning rather than judging, and recognizing and understanding how to effectively and efficiently operationalize system-wide empathy across diverse populations. This can be done by privileging the voices of lived experience, as we said, through co-design and through fully engaging with the human experience. We have a quote that goes along with this. This speaks to a participant who felt like they were having to prove that they needed a certain accommodation. I shouldn't have to go up to staff and say, quote, "I've got crappy knees. Here's all the scars to prove it. Please let me off the front." That takes away my dignity because I feel like I'm begging to be treated with respect like everybody else.
Recognizing the dignity of impairment and disability, as Kelsey has just elaborated on, increases comfort, security, and feelings of respect for people with disability when interacting with systems and services. Participants across all three studies discussed the heterogeneity of lived experience and the desire for systems to provide, use that word again, flexible services and care provision based on individual preferences rather than medical diagnosis or assumed functional requirements. In this section, we're talking about creating spaces for voice, choice, and independence, and providing opportunity for participants to express their individual preferences can prove challenging at times for systems, particularly for staff, as Kelsey has addressed, with organisational imperatives and resource pressures. However, creating space, my computer is now not doing the right thing. However, creating space for open discussion and recognising of preferences decreases vulnerability to undignified interactions, experiences, and outcomes. And participants closely related dignified interactions with systems and services with the opportunity to express agency through voice, preference, and independent, albeit supported sometimes, decision making. Our key recommendations here are to create opportunities for people with disability to express their own preferences, embed opportunities for choice and agency in policy and procedure to support staff engagement, regularly review preferences and choices to respond to fluctuations in impairment and capacity, and co-design system change, policy and procedures with people with disability. Creating flexible services that respond to the preferences and choices of people with disability. can result in more dignified interactions and outcomes. The historic erasure, dismissal, and silencing of and patronising of people with disability as the authority of their own. Sorry, just bear with me 1 second. Where was I? I'm going to start that section again. The historic erasure, dismissal, silencing, and patronising of people with disability as the authority of their own experience and care, particularly in health service settings, must be addressed in order to increase dignified experiences and interactions. Embedding opportunities for people with disability to express choice and enact independence should be implemented across policy and procedure. Activities similar to the palliative care patient dignity question, which asks, what do I need to know about you as a person to give you the best care possible, should be examined, implemented, and regularly reviewed to reflect continuity of care, but also the fluctuations and changing of preferences and capabilities. Policy and procedure change needs to happen to embed space for expression of voice, choice, and independence. This will be bespoke and consider the organisational constraints and factors of each system and service, which Kelsey's already spoken about. But community consultation and undertaking co-design of system change is imperative in order to better understand the system's specific barriers that limit voice and choice. One final quote here is, dignity is making sure my wants and needs are respected and I'm not treated like some inspiration or burden.
Thank you, Angel. And that ends our presentation portion of today's Hopkins Hour. And we are going to move on to our panel portion. So I just would invite anybody who has questions to type them in the chat so that we can respond to them as we go into the panel. If you haven't yet put a question in, feel free to do so. I'd like to now, of course, introduce our panel. So joining us virtually is Dr. Dinesh Palipana, OAM, Brooke Wadsworth, and Rachel Jones. Dr. Palipana is a doctor, lawyer, researcher, and disability advocate. He was the 2021 Queensland Australian of the Year and is the Griffith University 2021 Outstanding Alumnus of the Year. He is the first quadriplegic doctor in Australia and currently works in the emergency department at the Gold Coast University Hospital. He is also leading with us a Dignity Project research initiative with the Gold Coast Collaborative Health Scheme on dignity in rehabilitation. I'm also honored to welcome Brooke Wadsworth to the panel. Brooke is an advanced physiotherapist and team leader at the Metro North Health and Hospital Service STARS service, which is the surgical treatment and rehabilitation service. Brooke is a regular research collaborator and partner with the Hopkins Center and is committed to maximizing outcomes for people with spinal cord injuries. She's passionate about person-centered and collaborative research, person-centered care and collaborative research. And last but certainly not least, we are joined by Rachel Jones. Rachel is a clinical nurse consultant at the Spinal Injuries Unit at Princess Alexandra Hospital and with the Division of Rehabilitation, Metro South Health. She's a research assistant collaborating across various projects with the Hopkins Center. She's a well-regarded and respected nurse project manager and is passionate about providing ethical and dignified care. So I just invite all of our panelists, thanks so much for joining us. And feel free to turn on your mics so that we can hear all of your beautiful voices. And we're just going to start with a couple of questions for you all. Obviously, there's a range of recommendations that we talked about that may or may not relate to your individual clinical practice. So just want to, if you can each go around and share why you feel that dignity is important for the work that you do and the ways in which you might relate to the recommendations. So start maybe with Brooke.
Thanks, Kelsey. Thanks, Angel. Thanks for having us part of this session. Gosh, I think the thing that I think of the most, because my experience is in the spinal cord injury rehab service, and the biggest thing I would say is I treat and speak to anyone and everyone the exact same way, whether you're my friend, a colleague, a patient, and so forth. So my tone doesn't change. I don't use, "Hey, love, how are you? What can I do to help you today? Oh, gosh, you must be having a really hard time." I certainly keep my language very even, and I would also like to emphasize the fact that it's asking the question about, how are you today, and what can we do to suit you or address what you need to get done today. I think that's important as well, not just in acute rehab, but when you're seeing people as follow-ups for outpatients.
And Brooke, I know personally that you're very passionate about dignity in care. And why is that from your perspective? And why do you think it's important?
Oh, I think it's essential to excellent care. So I don't think you can do that and say that you're providing gold standard of care if you don't have a real strong guidance with acknowledging dignity. I think, yeah, it's essential. I guess I've also had family members that have been in a position where they've had their dignity challenged as well because of physical disabilities and so forth. So I do have a personal experience there.
Great. And how about you, Rachel? Same sort of questions. What do you think you do in your practice to ensure dignity for your patients, and why do you think dignity is so important? I think it's especially valuable from a nursing perspective because you really are the front line of the front line.
So one of the things that might be a little bit different to Brooke is that obviously we are invited into someone's very personal space. Unfortunately, in the hospital environment, when you come into somewhere like the spinal injuries unit, your privacy is very much invaded. And it is very personal care that's happening. It's bladder, it's bowels, it's skin, it's all of these things. And to try and help somebody to maintain their dignity whilst you're dealing with all of these things is absolutely essential. A lot of people who come into the hospital environment have never actually been in a hospital environment before, have never been naked in front of somebody other than, say, their partner or the people they live with, and they're facing being naked in front of multiple strangers on multiple occasions. So dignity is absolutely vital in that environment. Yeah, and maintaining that dignity, helping them to know that, look, you're completely covered, nobody can see this, because if you can't feel a region of your body or something like that, you don't know if you're covered, you don't know what people can see or what they're looking at. Just trying to help people every single day maintain a small part of themselves among the chaos that they've entered.
Great. Thank you, Rachel. That's really insightful. And I think that is one of the challenges, isn't it? That you're providing this necessary, albeit vulnerable care and finding ways to maintain dignity. I think that's was echoed in what our participants shared, just the importance of those of frontline staff really paying attention to that dignity. And even if you're having a bad day, to sort of leave that at the door and engage in that way with people. Uh, Dr. Palipana, over to you. Same sort of question. I know you come at this from both a clinical perspective and someone who has lived experience of rehab, and you're also definitely drinking the Kool-Aid in the research that we're all doing together. But I'd love to hear more from you about why you think dignity is so important and what you do in the emergency department to maintain dignity.
Yeah, totally. Can you hear me okay?
Yeah,
Awesome.
great.
All right. So, first of all, thanks for having me. And I was really touched by what Brooke and Rachel were talking about. And I've got to say, not everyone is like Brooke, where you'll talk to everyone with respect and dignity. And I think that's really important. And my journey as a patient over the last 12 years in particular, since I had a spinal cord injury, But something that's not as well known is also I was a patient having an experience through depression before the spinal cord injury happened. And through either of those experiences, there were often times where I felt very undignified. And Rachel was talking about being naked. I mean, before the spinal cord injury, I chose to be naked a lot in public, but after the spinal cord injury, I had no choice about being naked. And I think we, in healthcare, I really like this quote that is attributed to Mahatma Gandhi, and I think it will make us think about why this is important. And I'm going to paraphrase it a little bit to fit, but it's essentially what he said as well. And it is that a patient is the most important visitor on our premises. We are dependent on them. They're not an interruption to our work. The patient is the purpose of our work. They're not an outsider to our business. They are a part of it. We're not doing him a favor by serving the patient. The patient is doing us a favor by giving us the opportunity to do so. And I think that sums it up so well, right? And I think the damage that we can do to people by not taking that approach, by not respecting them, by not giving them dignity, is so destructive to the therapeutic relationships that we can create. And even for me now, I hate going to a hospital as a patient. I won't turn up unless I'm extremely sick. And we do that to so many people, and it's probably what's created this mistrust with the health system, mistrust with healthcare providers, driving people into the fringes of healthcare. So there are so many reasons why it's important, but those are just some of my perspectives.
Thanks, Dinesh. Yeah, I love that perspective on the patient. And I think it does hit home with this idea of person-centered care, and what that actually means is placing the person at the center of their care. And I think that relates to a lot of what we heard as well, Angel, wouldn't you say, across our research, is the fact that there is this fractious relationship between people with disability and health service providers, and that it is a place of harm. I want to get to just a couple of the questions that are in the chat. So thank you everybody for adding them in. Michael asked if there were 3 main points to give clinicians and community caregivers about dignity, what would these be? And I would love for each of the panelists to answer these. But I think from our research, Michael, our key takeaways are, of course, 1, to minimize access barriers wherever and however you can. 2, to provide that information clearly and in the way that your patient is requiring or needing that information. So whether it's written down, whether it's verbally, whether you're communicating it to them and their support worker or just them. And it's about identifying what those preferences are. And so giving opportunity for that voice, choice, and independence, and asking people what their preferences are. And even when then you cannot meet those preferences, being able to provide information for why you can't, and just really providing as much information in as respectful of a way as possible. That's my perspective on kind of the 3 main takeaways. Angel, did you want to add anything to that?
No, I actually just think that Dinesh did a beautiful job of saying everything that we just did in half an hour. But I think that the key takeaway from what Dinesh had said about his own personal experience, which echoes what my personal experience is choice. You know, we can talk about our recommendations and break it down into voice, choice, and all of these things, but really the single most important piece of all of this is choice, and being as transparent as you possibly can in your communication, in the way you provide these services, in the way you ensure that I notice there's a question here around the difference between dignity and respect. there is a significant overlap of those two things, so much so that we actually had to delve through a lot of responses in our analysis around, you know, how do we separate these two things, because they do overlap in so many ways. I feel though that dignity is a more core part of an individual, more so than what it is sort of contingent on other people. Whereas respect is really provided by someone else. We should really always know that respect is there, and we should just have that in our interactions. But whereas dignity, it has this deeper kind of impact on our identities. There's a lot more to dig into with dignity than I feel we certainly have with respect. I'm gonna finish there, but I think that choice is definitely the biggest thing that we can take away from all of our recommendations.
Yeah, thanks, Angel. And just to expand on that for a quick minute, because Michael and Tanya both asked about respect and dignity. I think for us, dignity is focused around that acknowledgement. So it's around acknowledging people with disability as full and capable human beings, which is often denied to them. And that piece of acknowledgement then triggers the respectful delivery of human rights. So I think that's kind of the interplay between the two concepts. And I like how Angel said respect is contingent on another person, dignity is inherent to each individual. That's at least kind of our understanding through the research. I can see, Dinesh, you have your hand up, so please feel free to jump in.
Yeah, thanks. You know, I think like we talk about all these practical things like accessibility and means of communication and everything. But at the end of the day, I think it's a matter of attitude. And if you are kind to someone, and if you're respectful to someone, and if you talk to them like a human being, which are just some of the most fundamental things, and just listen to them, I think that gets us 90% of the way there. You know, that's really what's missing most of the time. And not taking this paternalistic approach to where we think that we know what's good for someone and being so prescriptive. It's a collaborative effort. And I think our job is really to enable people to live the life that they want and enable people to get the outcomes that they want. So there are a lot of things, like a lot of practical things that we can do to make the experience better for someone. But at the end of the day, I think it's our attitudes as healthcare providers and as people involved in these processes that need to be a bit different sometimes.
Brooke or Rachel, would either of you like to jump in on any of those discussions? What might be the key takeaway that you would say to another clinician in your service or who you engage with? Brooke, can I put it over to you?
I'm thinking. I guess what I would say, because I work in a new service, having worked in the spinal unit for many years and moved to STARS, the two things that I would add in. One is modelling good behaviour as a clinician of treating and acting with dignity myself to my peers as well as the patients I work with, and modelling that and nipping it in the bud when I see that's not happening. And on another practical note, just simple things in a rehab environment, it's making sure people have got the right attire and clothing to wear. I see that when you've got new patients that are admitted, and knowing whether they've got appropriate loose-fitting clothing that maintains their dignity from a bodily nudity point of view, but also how we use the rehab space. In our rehab spaces are often big open gyms. We don't often have private rooms to do a private one-on-one session where there's a door closed and you can have a conversation with a person that's not just behind these curtains where you think no one can hear you behind these curtains, but they can. They can certainly hear you and often see bits and pieces of going on. So, yeah, I just acknowledging all of those.
Yeah, so I actually I think quite often when people come into a hospital environment as well, a lot of your handover and a lot of things that are passed on from other people is all about your injury and your past medical history. It's not about the person. It's not about their preferences. It's not about anything like that. So flipping that dynamic as well is very important, and making sure, you know, it's the next person coming on is aware that that person prefers X, Y, Z. You know, you don't have to have a reason for why they prefer it. They just prefer it. There doesn't always need to be a negotiation in regards to why somebody wants something. It's just their preference as a human being, and you need to honour that. So I think it's a lot of that communication as well that is missing in a health sector, whether that be the community sector or whether that be the inpatient hospital service. And I think, you know, just flipping that on its head is a very good place to start as well.
Yeah.
I think what I'm hearing, and certainly what we heard throughout this experience, was that flexibility is key, and we are dealing with environments and systems that are inherently rigid. The processes and the ways that we've been told to do things are there for a reason. You know, historically we've had things put in place and leveled on top of one another, and they all sort of overlap and intertwine, so it makes these systems very, very rigid. What we're trying to do is kind of open up those areas so that we can have some flexibility in between. We don't need to completely disregard the existing systems because they are there for a reason, but we can find malleability in those spaces to make sure that there's flexibility for clinicians and for patients.
Great. I just want to highlight a couple of things that people are mentioning in the chat because it's a really great discussion. Jeremy says, a definition I've often used with service organizations or policymakers is we, meaning people with disabilities, are not a byproduct of your service. We don't exist because of you. You exist because of us. And I think that really echoes nicely what Dinesh said. Annetta says, I sometimes use the analogy of someone going through the grieving process when in rehabilitation after their acute episode and asking staff to consider the stages of grieving when caring for patients. And I think that's a really, really important point. Gary says, having been treated without dignity and respect left me feeling like a burden, a bother, and despondent. And that echoes a lot of what we heard from our research participants, that the impact of undignified treatment is really catastrophic on an individual. It produces mistrust. It actually prevents the optimal delivery of preventative service. So we saw many of our participants who, as Dinesh said, would wait until something was an emergency, which is a greater chronic cost to their own lives, but also to the health system. And that in trust enables delivery of better preventative care. Dinesh, I can see you sharing a great photo. Do you want to jump in?
Yeah. So this was at the Australian Fashion Week last week, where they had a adaptive fashion collective, which was disability in fashion, and it was a great social conversation. But this particular image, I think, is really powerful because it's someone saying, "Fix the system and not me." And it's probably the system that really disables and takes away dignity from people the most.
I want to I can see so many questions coming through the chat and comments, so thank you, everyone. Two things that really strike me, and I know we have about 4 minutes. Helen asked, what sort of accountability mechanisms exist for patients who experience undignified interactions with staff? And she's relating it to her experience as a carer supporting a client in hospital. Staff consistently spoke to her instead of speaking directly to her client, despite giving feedback that that was okay, that was not okay. Sorry. Dinesh, you want to jump in on that?
I think there are some mechanisms, like in Queensland, we have the Ryan's rule and we have a few other bits and pieces, but I can tell you from my work now, after having seen thousands of patients, that there are a lot that slip through the cracks. There are a lot that are not able to speak up for themselves. There are a lot of vulnerable people that go through the system, like the elderly, and there are a lot that suffer unnecessary harm within the system, and those are the ones that we really need to look out for.
I feel like the reason that we have so many people who don't know how to advocate for themselves in these systems is there's a number of things, but I feel like you've all kind of echoed this sentiment, is that the system has allowed people to feel that way. We've created this kind of ecosystem where we've told people for so long that the system knows what's right. And when people either acquire an impairment or they come into a system like that and a historic legacy of attitudes like that, we believe it. And when we find ourselves in a situation or a circumstance, it actually throws our identities off. You actually believe what is being done to you is correct and is right, and you start to question yourself and your own identity. And I think that's really the key piece of this. If we start to create environments where we can actually provide people the freedom and the flexibility to learn about their identities, learn how to advocate for themselves in those moments, because we can't learn in abstraction, we have to learn in those moments. So those interactions are the places where not only clinicians learn how to provide dignity or maintain dignity, but it's also where people with disability learn how to afford it to themselves. And I think that's something to think about as well.
Brooke or Rachel, did either of you want to chime in? I know there's lots more comments and questions in the chat, and we will circulate them to the panelists, and we will send out an email with some responses to the ones that we haven't had time to answer. Does everyone just want to have some last concluding remarks?
So just in response to the person who said that the staff continuously spoke to them as the carer instead of the person that they were looking after, obviously there's always a channel at that point in time as well. Always ask for the most senior person on the shift to come and speak to you, or always make sure that you're escalating that at the time, and then follow it up as well, because that's not appropriate, obviously.
I don't think I have anything more to add. I think it's been covered really, really well. It's empowering the person to speak up, and that it's okay to have those conversations. And if you get the sense that someone's feeling like they're not being treated with respect or dignity, it's being open to have that discussion with them, even if you see it happening with another colleague or a care provider, which can happen.
Thank you, everyone, for joining us today. I did just want to address Camilla asked one quick question, which I think is a good thing to close on. I would assume that most people aren't trying to be unkind or disrespectful or make another person feel undignified. How do we make this recognized change on a big scale? And of course, we're all here because we're interested to start with. I think that's not always the case, but I think the things that Angel and I saw in a lot of our research is most frontline staff do have good intentions, but there is certainly a disconnect between the good intentions that staff have and the way that care or treatment or interactions are being perceived and received. And that's one of the really important pieces of work that we're carrying forward with Dinesh, Angel, myself, and a few other collaborators, is to look specifically in rehabilitation at the difference between staff perceptions of dignity and patient perceptions of a dignified experience, how they might be similar or different, and to use that to build a model of dignified care in rehab in order to promote change. So I think, yeah, it's really timely, and we're excited about working towards that. So thank you again, everyone, for attending today's Hopkins Hour. Thank you so much, Rachel, Brooke, Angel, Dinesh, for all of your insights. And of course, Angel for being the best co-collaborator these past 2 years, most patient and best co-collaborator. We really appreciate everyone making the time to join us today. We hope you found the session informative and that it gives you lots to take away and think about in your own practice or service or system. And if you'd like to get in touch with any of the presenters, please do so. And always, of course, contact the Hopkins Center to connect or request any documents to share from today's event. We do have copies of the PowerPoint that are available with or without speaker notes. So if that's something you might want, just get in touch with us, hopkinscenter@griffith.edu.au. And of course, we'll have a recording of the session. So thank you all, and hope you have a great rest of your week.